next year's will be even better. So I'll key in on that one.
Sweet.
Are your tests being the same format as Gary's?
Not my test, but Gary's test. Yep. So
Are we gonna go over it?
that's Monday. That'll be Monday. Yep. So I will catch you today. And
Yeah,
then
so I
we'll
can look at that
some
test,
stuff. Yep. So, all right, we get started on this.
Sounds good, man. Are you guys ready?
Yes.
Okay.
Everything that we learned yesterday is
Concrete.
in there,
Oh my.
stored in the hypothalamus, not going anywhere. Did you get that sleep?
Yes.
Yeah. I got some no's, some maybes, some sips of coffee out of frustration and anxiety.
Got plenty of that.
That's right. That's right. All right. So we'll just jump right into it, skip over those objectives. You guys go over those later, find out if you can answer those questions and have reached your objectives. But so what's the atrial kick?
The atrial contraction finishes filling the ventricles.
Okay, good. So yeah, it's that last 30% of filling the ventricles, right? What's happening during the atrial kick? All right, yeah, contraction. Atrial contraction, filling up the rest of the ventricle. Good. All right, so atrial dysrhythmias. This is abnormal electrical impulse formation, of course, and conduction in the atria. And we're going to go over a lot of the dysrhythmias and arrhythmias from the atria today. It can get a little confusing with these, I think, especially in trying to, look at the morphology and the waveforms of those complexes and trying to figure out, well, which one is it? And sometimes you can't tell. If the heart's going too fast, sometimes you can't tell. You don't know if this is just regular AFib. You don't know if this is. Sometimes you'll know it's an SVT, but you don't know which kind of SVT until you slow it down a little bit and can look at the morphology a little bit better. So they happen because of either altered automaticity. You've got triggered activity. Triggered activity is during repolarization or during the recovery portion. If there's depolarization during that recovery portion, that's called triggered activity. And then reentry. Do you guys know what reentry is?
Circles.
Something with the space shuttle coming forward.
All right, so yeah. So on the picture, it looks like a circle, right? So it's an impulse or a conduction that goes down through the conduction pathway. So it goes SA node, AV node, and then circles back around. So there's a pathway that enables that conduction, whether that's genetic or that's caused by injury to the heart, that creates this pathway that comes back up and then causes it to depolarize again faster, or sometimes it can be just like a PAC. PAC can be a reentry issue, and it's just a one-time thing. But so we'll talk about different kinds of reentry stuff. All right, so that's just definitions. So it can occur in the pacemaker cells. It can also occur in the myocardial cells that don't normally have pacemaker sites. But because of when this all formed, when you were in utero, you could have had migrating cells, and you might have pacemaker cells in places where you normally wouldn't, and it creates this this abnormal pathway or abnormal impulse. Let's see. So definition of the triggered activity. So this is the electrical impulse that occurs during repolarization, like we talked about, or like I said before in the previous slide, when the cells are normally quiet, right? Normally trying to relax, and then you get this triggered impulse. The re-entry, this is just specific definition. We talked about this. It returns to stimulate the tissue that was just fired. So these are a couple of pictures that show you re-entry, right? So it can be because of a block. So you see there could be unidirectional blocks. So the impulse can gets blocked when it goes through, but there's a pathway that circles around, and then the impulse can go back through that area that was blocked previously. And sometimes it's just a delay. Certain tissues will be slower in conducting the pathway, and so on the other side, it's faster and gets to the delayed portion and goes back up. All right. So you see, I mean, the example on the picture, that fork and the Purkinje fibers, normally there's no connection between that split, right? There's a connection between the split. It can circle back around and go back up. Does that make sense? The accessory pathway is there is extra pacemaker cells in places where there normally isn't, so it creates this circular accessory pathway, and the conduction goes back up and then fires the atria again a lot faster than your normal sinus rhythm would have fired, and creates this extra beat. If it's bad, or there's an electrolyte abnormality, the body becomes stressed, there's myocardial infarction, whatever, that reentry pathway can become constant. So then it becomes a tachycardic SVT type picture where it's continually circling back around, hitting again, and then that creates this fast reentry and tachycardic situation. So normally it results in a single premature beat, but then it can become a repetitive electrical impulse. Like I said, that results in tachycardia. So flutter, you guys know what atrial flutter is, right? Atrial flutter can be regular or irregular. Oftentimes flutter will look regular, but then you see these P waves that are going off and look like that sawtooth pattern. And the P waves will be at like 300, right? But the ventricular conduction system can't go that fast. So the ventricle will only fire every like 3 or 4 beats, depending on how fast it is. So the ventricle will fire at like 180 when the atria is firing at like 300. That can be an example of reentry.
So if you have to have the atria repolarized, and that's in the QRS complex, how come that electrical impulse is able to cause that flutter?
So the atria can, or at least parts of the atria can repolarize quickly because it's a small area. There's not as much tissue there. It's a thin-walled chamber, right? So there's not a whole lot of muscle mass. It doesn't take as long for that to repolarize. It can repolarize fairly quickly. And so, like, if you think about a normal QRS complex, that atria, you see the depolarization with the P wave, right? And you don't see the repolarization of the P wave because it's hidden in the QRS. That QRS is only 0.1 seconds later, right? Or 0.12 to 0.2 seconds later, or I should say milliseconds. So it repolarizes super fast, whereas the QRS complex has this delay and that ST segment, and then repolarizes with the T. It takes a lot longer for the ventricle to repolarize than it does for the atria. So that's one of the reasons why the atria can beat along with so many beats, but the ventricle can't keep up with it, and the ventricle can only get up to like 180. It really the fastest with kids, infants, where they have smaller heart, smaller tissue, can repolarize quicker, can get faster, right? They can get up to like 200, 220 sometimes. But so the ventricle can't repolarize as quickly, so it can't beat as fast. Does that make sense? And when you're in fibrillation, it's not really fully repolarizing, right? And that's why it's in this fibrillation shock state where it's not giving a full contraction. It's kind of going back and forth, and it doesn't know what it's supposed to be doing. Mm-hmm.
So, are you seeing part of that depolarization
In the P wave?
Yeah.
Yeah, that soft tooth when it's coming down. It's part of that, yeah. All right, so let's see. So we're going to talk about different kinds of the reentry pathways. You've got AVRT, which is atrioventricular reentry tachycardia. You've got AVNRT, atrioventricular nodal reentry tachycardia. And these are different kinds of SVT. And what does SVT stand for? Supraventricular. So that means that the impulse, the conduction system, is coming from where? Okay. And so which part of the conduction system is above the ventricle? Both the SA node and the AV node, right? So your reentry is a lot of the times going to be going through that AV node. All right. So, most of the time these are not life-threatening, right? You get patients that have SVT all the time. They're anxious because their heart's hacking away, but usually it's not dangerous. Sometimes it can be, but those are very rare circumstances. I can count on my hand the number of times I've had to electrically cardiovert an SVT. Most of the time you have time, you can slow it down, you can give them adenosine, and you don't necessarily have to shock them. We shock them in those unstable states where we just don't have time to mess around, right? Adenosine's quick. If you got a good nurse or, you guys are quick, you guys have adenosine, right? If you can get that out quick, you can certainly give adenosine in an unstable patient because it's quick, right? How do you have to administer adenosine? IV. You want a large bore, not a central line, but you guys wouldn't have to worry about that anyway. But yeah, like a good AC, whatever, good IV, and how do you want to push it? Fast, right? And you want to follow it fast with a flush. So it's like push, flush, like done within 3 seconds, right? Good. So premature complexes. The definition of the premature is that it's beating before the normal sinus rhythm cycle should be beating, right? Premature complexes can be atrial, so that's PACs, right? Premature atrial complexes. Can be at the AV junction. If it's at the AV junction, it's junctional. So that's premature junctional contraction. All right. The next lecture, we're going to talk all about junctional rhythms. Junctional rhythms all come from the AV node. And then there's ventricles, PVCs, right? And they'll have different morphology, so that you can pick them up. So if you have let's think about this from a conceptual standpoint. If you have an impulse and the conduction's going back up into the atria, that means that impulse is going the opposite direction, right? So it's causing contraction of the atria in the opposite direction. So how is that P wave going to look on an EKG? Right. So it's going to be inverted. Does that make sense? Now that's not to say a PAC. So it's inverted when it's reentry, when it's coming from the AV node back up. For like a junctional rhythm, it'll be inverted as well. But like a PAC is a premature atrial contraction. That's not necessarily a reentry. That's just other cells in the atria that are excited and are beating before the SA node does its thing, right? So that's still going down the conduction system, and that P wave is still going to be up, but it's going to look different than the P wave from the SA node.
So with those PACs, that's like AFib then, right?
No. So a PAC is, you'll only see PACs, like you'll see one PAC, you know, kind of randomly, like every 10 beats or every, you know, whatever. Depending on the patient's disease and how well the patient's doing, sometimes they'll go faster. And if you start to get runs of PACs, then it can turn into a full-blown SVT because it kind of takes over. And it takes over from what the SA node would normally do because it's going faster than the SA node. So the SA node's impulses are not getting through, and it'll start to take over depending on the disease of the patient or the state of the patient. But most of the time you'll see PACs and they're normal, they're no big deal, they're not going to cause any problems, and they're just kind of intermittent, right? Where like every 5 beats, 10 beats, 20 beats, and oftentimes it's just irregular, there's not a pattern. You'll just see every now and then you'll see a PAC, or every now and then you'll see a PVC, where it's an extra beat, and the morphology will look different. If it's a PAC, you'll have what? Meaning differentiating between a PAC and a PVC. So every now you'll get this normal sinus rhythm, boom, 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 and you'll see these PQRS complexes, and then after one of the PQRS complexes, maybe even before the T wave, maybe right after the T wave, not in rhythm, you'll see an extra contraction. You'd be like, well, that's a PAC or PVC. How can you tell the difference? Okay, so a PVC will be delayed, right? Because it's not going through the conduction pathway. It's not going through the SA node, AV node. It's extra cells, and so yeah, it's going to be wide. So you'll have a wider complex with a PVC than you will a PAC. Sometimes a PAC will still be a little bit wider than the normal, but the big difference between a PAC and a PVC. What does a PAC have that a PVC does not have? A P wave, right? So a PVC is extra cells in the ventricle, right? So there's no atrial contraction because it's contracting the ventricle. Now, eventually, that contraction will get up to the atria, just going through the muscles, right? Maybe, depending on if it can get through that fibrous layer. If there's like a break in the gap junction, it can still get up to the atria. But because it's contracting the ventricle at the same time, or even before, you're not going to see that, what the atria is doing. You're not going to see any P wave. So yeah, PVC, you're not going to see a P wave. PAC, you will. Both will look different than the normal sinus complex, right? Both will be maybe a little bit wider. The PVC will be even wider than the PAC. Does that make sense?
So the P wave on a PAC is going to look different than your sinus P wave, right?
Yeah.
Is that really the only way you're going to see it? Is a different looking sinus P wave?
Well, it'll be out of rhythm.
Okay.
And you'll have a different looking P wave.
So is there a chance you'd have essentially 2 P waves before a QRS, or is it still going to only be 1?
It'll only be 1. Yeah. You'd only have 2 P waves if you had re-entry, and the atria was continuing to contract, and the ventricle wasn't catching up.
So,
like you see in atrial flutter. Atrial flutter, you just see P waves going dum, 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 right? And then like every third or fourth, you'll see a ventricle.
So a PAC
ventricular
is
contraction.
not a re-entry issue.
No. It's extra pacemaker cell tissue
Okay.
that's firing. Just kind of, it's, you remember when we talked about excitability or irritability? So sometimes certain portions of those pacemaker cells will get excited. Excitability is usually caused by some kind of disease. It can be caused by caffeine, cocaine, medications. It can be caused by stress and anxiety, where the heart is getting, different neurotransmitter signals from the body, fight or flight mode, whatever. That can cause, if the patient has this extra pacemaker cells in other locations where it normally shouldn't, it can cause that to get excited and start going. Does that make sense?
Yeah.
What lead would we see this on a 12 lead? And are we going to have a detailed explanation of each one?
Of each of the leads?
Yeah.
For the most part, when you're looking at atrial rhythms, you're looking at lead 2.
Okay.
All right, so lead 2 is where you're going to see P wave morphology. Because in other leads, even in normal sinus rhythm, you're going to see P waves that are inverted. You're going to see, different things depending on where they're at. When we're talking about these normal complexes and where you're recognizing changes in morphology, you're looking at lead 2. All right? And no, you don't have to memorize all the different changes in morphology in all of the leads. That would be ridiculous, and I think redundant. I think that's wasted information. So we talked about these. Where did I just go? Know that? All right. So premature complexes. Okay, so you can have pairs where you have 2 in a row. You can have bursts where you'll have normal sinus rhythm and you'll have like a burst of PACs in a row. We talked about yesterday, you can have patterns. So this is the exactly regularly irregular patterns where you have bigeminy, trigeminy, quadrigeminy, depending on how many beats. All right, so it's like every third beat would be a trigeminy. Every other beat, 2 to 1 is bigeminy. All right. So like I was saying before, they occur in an irritable site within the atria, and they're discharging because they're excited, because they're irritated, because of whatever impulses or stimulation they're getting. They become excited and they discharge before the SA node impulse does. And if that does it for them, and they're not super irritated, super excited, then the SA node will take over again. But if they keep beating away, then they'll take over for the SA node. So you'll see different morphology of the P wave in a PAC. Sometimes they can be biphasic. Sometimes they can be flattened, where you just see it's barely kind of rounded. Sometimes they'll be notched. Sometimes they'll be pointed. I would say most of the time they're more of in a pointed morphology. And sometimes if the patient's tacking away, you won't even see those. And if they're going really fast, sometimes you can mistake P waves for atrial fib. If they're not in a pattern like a bigeminy, trigeminy, but they're excited enough to be present, it'll be like every 2, and then every and then on the third one, and then on the second one, and then on the fourth one, then on the fifth one, and you won't see any P waves because it's tacking away, and you can't see the P waves because they're hidden in the T waves. And what will it look like then? It'll look like AFib. You won't see any P waves, and it'll just look irregular. So sometimes AFib and tachycardia with frequent PACs will look the same. Does that make sense of why it would look the same? All right, so here, how do you recognize the PAC? Where is it? There's a couple of them. So if you weren't looking at the P waves and you just quick glanced at this strip and were looking at those R waves, what would that look like?
Three short bleeds.
It looks irregular, right? And it looks irregularly irregular. So if you're not looking at the P waves and you're just looking at the R's, which some people do, some people that just don't understand EKGs really well and just recognize patterns, we'll look at that and be like, oh, that's AFib, because they're just looking at the R waves. But of course that's not AFib because there's P waves, right? So you look at that and you're like, okay, that's irregularly irregular. Why is that? And then you start looking at it a little bit closer and you're like, well, some of the beats are regular, and then you've got this beat that is just faster, and then it goes back regular, and then a beat that's faster, and you look at those P waves and you can see the different morphology in those premature beats, right? So you guys can reckon. So where are they? You've got one in the 2nd, in the 7th, and the 10th, right? Those are all PACs. So your second complex, you've got this spike in the P wave. So as you're looking at this, normally you want to take your eyes to where there are regular beats. So that spacing looks the same. That space, those are all regular beats. Those P waves are all the same. So then when is it different? It gets shorter right there. That P wave's different. Come back here and be like, oh, well, that P wave's different, and that's a shorter beat than where it should be. Because this distance is the same as what it would be if it was regular, right? It's just that middle one beat a little bit closer. If it was right there where it should be, it would follow the same pattern. Does that make sense? So the two R's is that same distance. Which notch?
Towards the right. Right there, yeah. What's that?
So you can see, even in a lot of these regular P waves, you can see a little bit of a notching. So there is already some disease in the way that conduction complex goes forward, and that's probably why they're having pretty frequent PACs, is because there's already some morphology differences and disease in the atria.
So with the PAC, why would you see the higher P wave?
The peaked P wave?
Yeah,
So the PAC, oh, you mean just from like conceptually?
a little bit, I guess. Jeff, help formulate my questions.
So if you have your right atria here, left atria, you've got your right ventricle, left ventricle. Normally that SA node is here, right? Then you've got this conduction pathway, and then you've got this node, comes down, splits off. You got your Purkinje fibers. So PAC is from excited tissue elsewhere, right? So you might have excited tissue all the way up here. You might have excited tissue here. You might have it in the back wall, in the front wall. So because it's going down the pathway differently, but your EKG or your pad that's sensing that electrical activity is in the same place, but the impulse is coming from a slightly different location, it changes the morphology of the P wave. That's why sometimes it can be flattened. And that would be if that excited tissue is like all the way down here. So you just don't see much of an impulse, right? It's just slow. That is probably from excited tissue that's all the way up at the top. So it's showing a different electrical impulse and a little bit higher and stronger one. Okay? Because you're getting a greater distance to that AV node, so you're having a stronger electrical impulse, and that's why the P wave looks beefier. Does that make sense?
Yeah, so then you could have flat looking P wave if it was lower in the atrium.
Yeah.
Okay. Would it be wider if it originated like on the wall, sidewall, like that? Is it not like that?
I don't know.
This has to do with the
It might be.
direction it travels to that lead, so that
Right.
it's showing that direct path, it should be spiking bigger. If it's showing a
Exactly.
horizontal, it's coming out flat out.
So your greater amplitude is a positive deflection, right? So that's going to be if the pathway is towards that positive lead
Yeah.
in a straighter direction. All right. When it starts to veer off is when you're going to get different morphology. So it'll depend on which direction it's coming in. So if your lead is out here, and that electricity is either really close to, so it's just not traveling very far and it's coming straight up, or it's in the back wall, so it's kind of coming this way. The impulse is coming this way towards the lead. Then that might give you a bigger spike because it's a straight shot in that
As opposed
electrical.
to the opposite.
Right. Now this is, I guess, less important, but conceptually good to know that that's why that morphology changes. But of course, you're not going to be tested on, well, what if they're, if it's spiked or if it's flattened? Where in the atria would that tissue like? That's almost impossible to know, right? You had a question or no? Yeah.
No, I'm just
Okay. Just flapping your wrist around.
flapping the wrist around.
All right. All right. So, I mean, this gives you, it's the same lead as we were looking at before. It just shows you where the PACs are, right? So which ones are coming from the SA node and which one is kind of that premature extra beat. All right. Now, if you have notched or you have biphasic, where it almost looks like two, what do you think is going on there? Just from a concept. No, where you have PACs just like this, but instead of the spike, you'll see.
So one atria that's setting off the other atria.
Right. So you might have where one impulse is stimulating another impulse, so you get kind of almost two impulses coming down in different directions. So that's why it's going to be notched and almost look like two P waves together.
Could you also see that from the SA node and your excited
tissue?
node
Yeah.
setting off?
So that might be why you have this notched effect in the normal P waves, is because it's also exciting the other tissue, right? The impulse is coming from the SA node, but it's exciting the other tissue. So you're getting a generated pulse quicker to that other tissue, and so it's almost like it's branching out into the muscles in two different locations, and you get that notched effect. All right. So yeah, the PR interval, it can be normal. It can be a little bit prolonged, depending on where in the atria that tissue is. So the QRS is usually normal in a PAC. It's usually not wide unless you have aberrancy, and we'll talk about that and what aberrancy means. And that's usually a junctional thing that causes a delay. Okay, aberrancy is a delay in the impulse, and that is what will make the QRS a lot wider if there's aberrancy. So sometimes, and I guess we'll talk about that later, the only time it's really important to know aberrancy is looking at what looks like a ventricular tachycardia. So you got a V-tach because it's wide, right? So when you're looking at tachycardia, you're saying, well, is this a narrow complex, or is this a wide complex tachycardia, or is it just normal sinus tachycardia? If it's a wide complex tachycardia, that's V-tach, right? Sometimes you can have a narrow complex tachycardia with aberrancy. So it's coming from, it's a supraventricular tachycardia, but it's wide and it looks like V-tach. It's actually, so it's going to be, in order to treat it, you have to treat it differently. Although cardioversion, synchronized cardioversion, if the patient's stable enough and you've got time, you do synchronized cardioversion for either. So it really doesn't matter if you know the difference or if you can identify the difference, you just shock them.
You still need the adenosine to try to-
Yeah, for both of those, you can give adenosine. For WPW, we generally don't want to give adenosine. Now, there is some controversy over that. Some cardiologists will say, yeah, it's fine, give it to them, and we can find out if they have it. But if you know a patient already has WPW and they come in with tachycardia, we generally don't want to give adenosine.
So
Or beta blockers or calcium channel blockers.
what sort of issues do PACs lead to?
Most of the time, it's normal. I mean, almost everybody in this room has probably had a couple PACs during this lecture, and you never know about it. Now, if you get really anxious, then it might start becoming a problem, but it depends. PACs, it depends on how excitable that tissue is, and it depends on the disease of the patient. So a normal person might have excited tissue, and it might go off every now and then, and they would never know it, and they'll live their whole life and never have an issue with it. If they have poor diet, poor lifestyle, they smoke all their lives, they have a bad heart, and they put strain on the heart already, that tissue starts to become a problem, starts to become excitable more often. If they get sick, if they get septic, you'll notice septic patients that have heart problems come in with AFib RVR all the time, right? And it's hard to differentiate. Well, they're AFib with RVR, but they got a huge fever. Well, then sepsis put them in a stress state to cause the AFib with RVR.
I might have missed this in your talk. When they grow the PVC or PACs up there, I see this why the long complex after that?
What do you mean, why the lung complex after that?
Where the
Why the space?
Yeah, where you throw in the PACs here, you got here, and then it seems longer.
Right, it's
And
wider
then
than,
it's wider, and then it's wider.
right.
Is this the heart resetting?
This is, yeah, exactly. It's SA node resetting, because that distance between this regular complex and this regular complex would be the same as this distance where it would normally be.
Okay.
Does that make sense?
Yeah,
It's
absolutely.
just that, so these are all normal beats.
Right.
This distance is actually the same as this distance. It's just that this PAC went off before the SA node could have right in the middle there.
Okay.
And then the SA node's resetting and it's going back to its regular beat.
Okay, I just want to make sure I understood.
So yeah, if you took out the PACs and put in a regular one in the middle, it would be the same. I mean, that would be completely sinus rhythm, right?
Okay.
So even though the PAC, isn't that causing the SA node to fire? Because it's gonna, whereas the SA node.
No, it's contracting before the SA node. So the SA node gets this impulse and it's already depolarizing. So the SA node then has to reset and go back to what it wants to do with its automaticity, right?
This he felt as palpitations or
Yeah, if you're getting PACs probably that often, they'll start to feel those. And so they'll feel palpitations and I don't know what's going on.
Came into you with this rhythm or just PACs. Do you treat it at all? or-
I do a couple labs. I look at their electrolytes. I look at maybe a TSH, see if there's other stressors that are causing them to have more frequent PACs. And then if I don't find anything from a medical standpoint, I'd have a follow-up with cardiology and probably get a little bit more cardiac testing, echo, see if there's any other disease with that heart.
I mean, you can have PACs that reset that signal, right? Because you have compensatory and non-compensatory.
Yeah, PAC can reset the SA node.
So I mean, sometimes you won't have that long pause afterwards.
Sometimes you won't go back into, I guess, that
The initial-
where the complex should be. Right. All right. So we identified that one. All right. So recognizing PACs. So the rate when you're looking at PACs, the rate's usually in that normal range. And the rhythm is regular. You just have identifiable premature beats. Does that make sense? So this gives you that in lead 2 again. It's positive and upright. You can identify those P waves in lead 2.
Like Chris was saying, or yeah, even though it's not technically regular, you would kind of extrapolate that there would be a regular rhythm there for this piece.
Right. So you would not identify that strip as irregular. You would identify that as regular sinus rhythm with intermittent PACs. Because they are just intermittent, right? There's no pattern to those PACs on this strip.
That's pretty normal.
Yeah, it's not normal to have them that frequent.
Right.
You could have a run of PACs like that, but hopefully it's not constant intermittent PACs. If it's constant intermittent PACs, then you want to check stuff, see if there's anything else going on.
So if it's bi or trigeminal, then you'd be thinking like maybe we've got more of a problem.
Yeah. And they can go in if it becomes a real big problem, and it's consistent, and medications aren't helping it. Because you can treat PACs, you can give them a beta blocker, like a low dose beta blocker, to try to keep that conduction system in a regular setting, and so that those things don't get excited as easily and can't get tachycardic. So you can give them a couple of different medications. That's why I would send them to a cardiologist if I didn't find anything, obvious. Cardiologists put them on a low-dose beta blocker, calcium channel blocker, try to slow down that heart rate, see if they can control the frequency of the PACs. If they can't with medications, then sometimes they can do an ablation. You guys know what an ablation is? They go in and they burn the tissue where they think that impulse is coming from.
Lidocaine, stuff like that.
Lidocaine and procainamide, some of those things can help, but that's pretty rare. Flecainide, procainamide, we don't usually give lidocaine other than, the only time you'll ever see lidocaine really is with ACLS and trauma. I mean, in emergency medicine. People usually are not on lidocaine anymore. Used to be, but we just have a lot better medications now.
This going back, this one here, you didn't have the P waves, you would call them
Yeah, so if you're just looking at the QRS complexes, and you're just kind of looking at it at a glance and looking at the R waves, it just looks completely irregular, right? Because of those intermittent PACs. So you're going, oh, at first glance, that's AFib, but then you got to look at the rest of your complex. You see the P waves, and you're like, wait, that's not AFib. Maybe there's a pattern there. These P waves look different than these P waves, and you sit and try to identify what pattern is going on. So like Craig was talking about, there's a difference between compensatory and non-compensatory pauses. You read the chapter, didn't you? No. You're just. Oh, I see. All right.
That was the whole question that Chris was asking, right? Was the left compensatory pause, right?
Yeah, maybe.
You were just before your time, dude.
So this non-compensatory or incomplete pause following the PAC, that's the delay when the SI node is resetting, right? So that's the non-compensatory. So in this strip, what we're talking about, that's non-compensatory, where it's pausing and getting ready for the next beat.
So if the SA node used that PAC as its timer, that would be a compensatory, and we'd see a normal distance between the R to R following a PAC.
Wait, say that again.
If the SA node, I'm trying to get, and that was I read this last night. I struggled with the difference between non-compensatory and compensatory. And non-compensatory is the SA node doesn't use that PAC as its rhythm. I mean, it's not like that.
Right. Non-compensatory does not.
Whereas a compensatory, it does.
It recognizes it.
Okay.
Right.
Okay.
So to decide whether it's compensatory or non-compensatory, which really is frivolous, and that's something that clinically doesn't matter.
Okay.
Right? Well, is that compensatory or non-compensatory? That's like, you know, that's for researchers. But from a clinical standpoint, does it matter if it's compensatory or non-compensatory? At least from the patient standpoint, probably not. So identifying that on a clinical standpoint isn't that important. But in order to figure out if it's compensatory or non-compensatory, you try to find where there's 3 regular beats from the SA node and measure the distance between those. Like I was saying, right? The distance would be the same if it was there. And you compare that to your PAC beat. All right. So the pause, meaning that wider gap, that's the non-compensatory. So I don't know if we, in this strip, okay, that goes right back to it. Non-compensatory pause, that is different. If it's the same, then it uses it.
So do you go longer PR interval as well, or?
With PACs in general?
No, yeah, with PACs.
It depends.
With the non-compensatory pause?
Non-compensatory and compensatory won't matter with the PR interval. So PACs in general will change the PR interval a little bit depending on where it's coming from, right? So it could be shorter and it could be even a little bit longer. So aberrancy or aberrantly conducted PACs. So this is when the PAC shows a wide complex. It's because there's a PAC with aberrancy. And if you can identify aberrancy and call that out on an EKG, you would confound docs, because I would say most ER docs don't know aberrancy well enough to see it on a regular basis. They wouldn't be able to point that out on an EKG. Oh wait, that's not a PVC, that's a PAC with aberrancy or whatever.
What is aberrancy?
We're going to talk about it.
That's just trying to lead into you.
Right. So when you have a PAC with a wide complex QRS, that's an aberrantly conducted PAC. It means that the conduction through the ventricles is abnormal. It's delayed, right? It's not going through the same pathway where you'd have through the AV node, through the bundle of His, through the branches, through the Purkinje. You'd have that normal contraction with a normal QRS. If it's abnormally stimulating the ventricle, it's going to be delayed. It's not going through the pathway. It's going through the muscles, and it's going to be delayed, and it's going to be a wider QRS. That's an aberrantly conducted PAC. It's still generated from the PAC, but it's causing the ventricle to contract abnormally.
Do you usually get the widened P wave as well, or? That's what it is. Yeah.
What did you say, Craig?
So it's
Not a
T
wide
wave
of
with
the
a
T
very
use a T wave with a buried P.
Right. So you see that the notch, the first aberrantly conducted PAC, the reason why that PAC looks different than this other PAC that's conducted normally is because it's starting
Into T.
during repolarization, right? So it's a T wave with a P wave in it.
Well, because that second one, there's no T wave either.
Right.
It
Well,
So the PAC, that premature contraction contracted before real repolarization from the ventricle.
You can even see it, look at the other T waves, and see how it doesn't have the same morphology of the other T waves.
Oh, yeah.
Right?
I'm more than that.
So, yeah, so we see that and see it's higher than P. It's probably the difference is because there's a P wave in there. I mean,
Right.
there's P at the same time, which causes that elevation. Okay.
You just have both impulses seen in that.
Then does that also have like AFib in there as well? Because like, looking through it, you can see the QRS complex for the first one, the T, and then there's a little bump there. Would that be a P wave and then another P wave for the next complex, or is that
Say what?
on that one? If you look at the first complex, and then just after the T wave, it kind of goes up to another bump there.
What's that bump after the T wave? It's a U wave. So it cannot be AFib because why? You have P waves. You don't see P waves in AFib. Why? Because it's just a stunned atria, right? There's no really full contraction. It's just fibrillating. So you just get this kind of undulating baseline. So this is what you guys were already identifying, is that PAC can occur close to or with the T wave. So let's see if we can. So in this one, the PAC happened, during that T wave, but, and it could have been just a millisecond late enough that it still gives a QRS, right? And this one, that, and the morphology of those two T and P waves look fairly similar,
Dr. Ray,
but you had a PAC that was blocked.
we don't see your mouse when you're moving, so if you can just
Okay,
show us
so
on the board.
so look at this morphology, and you have a QRS that's after it, right? And you have a aberrancy because it's wide, right? And then look at this T wave and P wave. It looked about the same as the previous, right? But the previous, that P wave or that PAC happened late enough in that repolarization that it was still able to give a QRS complex on the previous slide. And it showed that widened QRS complex. It was delayed. It was a crappy complex, but it was still able to do it. This one, it happened too early in repolarization, so it was not able to stimulate a QRS complex.
So still in the refractory period.
So yeah, so the PAC happened too early in the repolarization, and then there was no beat. Does that make sense? So it was blocked. It's a blocked PAC or non-conductive PAC. Right. Yep. Exactly.
It's normally not just like a one-time event, though. Does that indicate disease or some other cardiac problem?
No, I mean that's just a PAC that happened like too soon.
Okay, so just kind of go, oops, and then everything else is good.
I mean, it would be the same, at least from a prognosis standpoint, as your normal PAC. It's just that it happened too early in repolarization, so you didn't get a beat from it. You might feel that maybe a little bit, if you were more sensitive, just because you don't get the beat. But all right. So what causes them? Emotional stress can cause PACs. So I actually see patients all the time, and it's hard to explain that to a patient, especially somebody that comes in with a lot of anxiety. I know something's going on. I'm feeling palpitations. And, well, are they stressed because they're feeling a lot of palpitations? Or are they having palpitations because they're stressed? I don't know. So I'll do various tests on a patient, and if it all comes out normal, like, well, this might be anxiety, and patients don't like to hear that, right? It's not in my head. But it might be. The mind can control the body. All right, so congestive heart failure, acute coronary syndromes, fatigue, stress in general, DIG toxicity, and remember that's that medication that we talked about. What does it cause on an EKG? DIG, the DIG swoop, DIG dip. Hormone issues, hypothyroid, stimulants, caffeine, tobacco, cocaine. I'll get regulars that come in with SVT, or sometimes regulars that will come in with AFib, and always they're like, "Oh, what did you have to drink today?" Well, did you drink any water? No, I had like 2 coffees this morning, and then I had 3 Monsters, and like, dude, and it'll be the same thing every time. And like, you're gonna keep having this if you don't stop having 200 some odd milligrams of caffeine every day.
So why would, I thought a PAC is a mechanical, there's a cell there that's excited. Why would emotional stress cause that, or some of those other things?
So emotional stress causes you which part of your nervous system to kick in?
That would mean your SA node should be firing more, right? Not a PAC.
Well, stimulants in general, so if you're getting, so the SA node, yeah, would fire in regular circumstances. If you're getting, signals, you're getting the norepinephrine, you're getting dopamine, whatever that's causing it to stimulate and, raise up or whatever in a fight or flight response. And that even just physical stress like that can cause the PAC to become more excitable as well, because it's also getting stimulated, and it's also feeling extra stimulation from the SA node firing all the time, and then it gets excited and it starts firing. Does that make sense?
Yeah.
So that can happen with emotional stress, just like it can with anything that would cause your sympathetic system to ramp up, right? Basically, all of those things, either there is a mechanical problem with the heart, disease, heart attacks, dead muscle tissue, causing problems with the conduction system, congestive heart failure, or you're causing the sympathetic system to ramp up. Anything that's causing that. Hyperthyroid, stimulants, the electrolyte imbalance, all of those things. Emotional stress, physical stress. So, like I was saying before, what do you do about them? Occasional PACs, they don't require treatment. Frequent PACs might initiate other stuff. You get frequent PACs that might jump into an SVT, might jump into AFib. So you treat the underlying cause. If there's an electrolyte imbalance, if there's something just with the heart in general, then you put them on a beta blocker, a calcium channel blocker. If you need to reduce stress, whatever it is. Stop drinking caffeine, which nobody ever does. Did you know from a medical standpoint, 2 glasses of water, so you're looking at like 8 to 16 ounces, depending on what you say is a glass, but 2 glasses of water in the morning will ramp up your system and put you in a better awake state than any caffeine.
So you give that
2 glasses of water in the morning and 2 glasses of water at night is more effective in treating hypertension than any medication we have. People don't want to do it. It's so easy. Well, that's one reason old people don't want to do it. You got an old bladder, Chris? My wife does. So does my brother. Like my brother, when we'd go on road trips, that kid had to pee like every freaking 30 minutes. Could not hold his urine. Yeah, we're just talking about bladders and peeing. All right. this is going. I don't know. We've got 2 hours to do sinus rhythms. We might need to speed it up a little bit if we're gonna make it. You guys want to just push through? Do you want to break?
Well, I drank my 2 glasses of water, so I need a break.
All right, then you got like 3 minutes.
Think we found the old bladder.
Do you want me to just turn it off or just leave it?
We'll try that.
Thank you. All right. So wandering atrial pacemaker, that's an old term. I actually never even heard of wandering, the term wandering, until I read your guys' book. Pretty much it's called multiform or multifocal is really the more common term for it. But just by the name, what do you guess is going on? Multiform atrial rhythm. So why would the size, shape, and direction of the P waves be different? What did you say?
There's multiple places in the region firing. So
Right.
there's not-
So instead of somebody just having one area where they've got extra pacemaker cells, they've got multiple, right? And all of them are firing at different times. So you're going to have a different morphology of P waves. So recognizing it would be looking at your P waves and recognizing that you have at least 3 different P wave morphology. That would be multiformed or multifocal. I don't know why they did this, but they call it multiformed when it's a normal rate, and it becomes multifocal when it's tachycardia, which is just semantics to me.
So can you go up there and show us? I don't really got inverted in it.
All right, so this is one kind of P wave. That one it's inverted as well, but it's a little bit different morphology, has a different kind of swoop to it. That one's a little bit flatter. That one's up and flat, and that's even more up. So you've got you could say that's 1, that's 2, and then inverted. You could count all of those as 1 and say that's 2 different morphology.
So we're just seeing something firing. Or when it's normal, we've probably got an SA node, right? Or is
maybe that might be an SA node. It's a little bit hard to say just because you don't have enough regular P waves to really decide which is the SA node. But that's probably the closest to the SA node. I mean, that could even be what their normal is. I don't know. I just don't have enough of the strip to tell. But they don't have to be. I mean, you don't want to get super, I guess, detailed with the morphology. I mean, you could you could argue that those P waves are different, right? But in general, you count all of the inverted P waves as kind of the same, unless there's a big difference like that. I mean, that's obviously different. That's flattened. That's more upright. So that's different. So you could just say you got inverted P waves, you have a flattened P wave, and you have an upright P wave. You've got 3 different P waves, right? Okay. Even if one of those P waves looks normal, it's different than the other ones, right? So that counts.
Do they have to be consecutive?
No, they don't have to be consecutive. You're just looking at a strip, and you're seeing different P wave morphology. That's multiformed.
so is that a form of a PAC?
Yeah.
Okay.
And in semantics, is multifocal and multiform, is that something in the field or just something in the book?
That's really more book.
Okay.
Most anybody in the field would just call that multifocal. But for the most part, unless you're a cardiologist, we don't identify that until it's a problem, and it's a problem when they're tachycardic. So most of the time when we're seeing it, pre-hospital or in the emergency department, it's multifocal. So the only time you're going to see it otherwise is if, for whatever reason, they get a random EKG and they notice that, oh, you've got multiformed PAC or P waves. All right, so it can be regular or irregular. Let's see here. All right, QRS is usually the same. PR interval obviously can be variable because you're going to have different kinds of P waves, and it can change from beat to beat. And that just defines more of what we already said. So this multiformed, it can be in healthy hearts. Athletes can certainly have it. I've never seen it in dig toxicity, but that's probably because I didn't recognize it. When a patient's dig toxic, their EKG looks weird and crazy already, and it's not necessarily clinically important to be like, well, he also has some multifocal stuff, but it can be there. But you guys will be able to recognize it, right? And then you can come in and say, hey doc, it's got this and this, and be like, man, you must have had a really, really good teacher. All right, so like I said, they usually don't have any problems if it's a normal rate or a slow rate. The only time it can become, it's clinically an issue is when it's tachycardic. All right. So when it's greater than 100, then we call it multifocal atrial tachycardia. We just call it MAT or MAT. And that gives you that chaotic tachycardia. So you're looking at the P waves. You can see that, and people will sometimes confuse MAT with AFib too because it's irregularly irregular, right? So you look at the R waves and you're like, oh, well, it's just irregular. Then you come down, like, oh, he's got P waves here. You could be, if you were looking at that real quick, you might think that the T wave is a P wave, and you're like, oh, this is flutter, right? But you kind of have to, you have to look at it as a whole and be like, oh wait, no, that's a T wave and that's a P wave. There's a P wave and that's different. That's a different P wave. That one's flat, and there's another one that looks similar to that. There's another spiked one. So we easily have, we've got notched, spike, and kind of a more rounded P wave. We easily have 3 different P wave morphology, right? So that's MAT. So we see MAT with severe COPD. Why do you think that is? When patients have severe COPD and they have a lung disease, it becomes more difficult to push blood to the lungs, correct? You've got lung disease and all those capillaries that are going into the lung tissue and causing problems with how flow is going in and out of the lungs. So you get backup, right? And the backup is into where? Right ventricle, right heart. And causes stretching, causes issues, causes these things to be more excitable and start firing off. Low oxygen, all these other reasons that are basically the same reasons why you can have any of these problems. But specifically, low calcium and low magnesium can cause a lot of different atrial dysrhythmias.
So why wouldn't that be just an irregular sinus tach?
That the strip?
Yeah. What was the reason?
So you're saying that you would call that like a sinus arrhythmia? Sinus tachyarrhythmia?
Irregular. Sinus tachyarrhythmia. I don't know.
So, right. So what's the definition of sinus?
Normal SA node conduction.
Right. SA node conduction down through causing a normal QRS complex, right? That's sinus. Why is this not sinus?
Morphology of the P waves, so
Right.
the electrical stimulating, but other places not the SA node necessarily. One can come from the SA node, but other ones are coming from other places.
Right now, with that, we don't even know which one's coming from the SA node and which one's not, right? We've got different formed P waves, so we know that that conduction is not always going through the SA node.
Gotcha.
That's why it's not sinus. That's why it's multifocal.
So, I'm sorry, but between each of those beats, there's you could say that's a T and a P, and they're just screwed up, right?
You mean where they're closer together here?
Yeah.
Yeah, that's T wave, that's P wave, that's T wave, that's P wave, that's T wave.
So
That's a
we're just
P
saying
wave
because
that's
our
really
P
not.
waves
That's T
between
wave,
each
that's
one
P
is so
wave.
goofy.
What's that?
Our T wave is, or excuse me, our P wave is not uniform, so that tells us it's not a sinus.
Right.
Okay.
Because the P wave in a sinus rhythm should be the same, right? Always going through the SA node and in the same. If you want to say, I've got a sinus rhythm with intermittent PAC, you can recognize a PAC that has a different P wave,
Okay.
but that's an intermittent PAC, and you're only seeing two different kinds of P waves. If you're seeing three or more, that's multifocal.
It's just a dip in the P wave. See how it kind of comes off the baseline?
You
and
mean
dips
just
down about-
just kind of
Yeah, about the
doing
same
this thing?
point. Is that like
That's-
a global ventricular?
Oh, that might be respirations. That might be just the patient moving. That's, it doesn't mean you can't compare this one, this isoelectric line with this isoelectric line.
I was wondering if it was something from the heart.
Right.
It could be
I mean,
what they're doing.
it could be the heart. It could be that they might have like a mild chronic tamponade, and so the heart is moving around in that
Or it just could be
space.
artifact or something from them.
Yeah, could be moving, could be a whole lot of things. They could be talking. You say, hey, that hurts.
So if it's just two types of P waves on the left side to be inverted,
Mm-hmm.
you would call that PAC with sinus. Or sinus with irregular PAC. And then if it's three or more, you would call three or more different types of P waves. You would call multifocal.
Yeah, three or more is definitely multifocal.
Okay.
If you've got two, yes, if you see a P wave and you've got different morphology and it's beating,
And then you get regular.
Right. then you would say, sinus rhythm with intermittent PACs or whatever. It might be in a pattern, bigeminy, trigeminy, but you're only going to see those two different kinds of P waves, right? And you're going to be able to recognize it. This looks like a normal complex. This is a different complex. And then you can recognize each time that different complex is beating, right? With multifocal, it's a little bit erratic because you don't know which one is going to beat at any given time to go through that pathway. So it's going to be very irregular, and there's not going to be any kind of pattern to which P wave is going to show up. Does that make sense?
And just a quick question. So in the field, as we're seeing this, is there anything treatment-wise that we're going to do other than we need to ship to the hospital to get looked at?
That would be, this multifocal tachycardia would be treated like an SVT.
Okay.
An SVT, where we just want to reset and kind of calm everything down and try to get the SA node to take over again.
So we would use it to be adenosine?
Yeah, you could give adenosine to that. Yeah, depending on how fast they were, symptom-wise, you could totally give adenosine to that. How fast is this going? What's your range? Yeah, between 150 and 100. So, would you give adenosine to it? Probably not. What would you do? Depending on what their heart disease is, what their lung disease is, I'd give them fluids and see how they do with that. I would try to treat maybe an underlying cause. This patient might have a fever, might be septic, might have just sniffed a bunch of cocaine, whatever. Treat the underlying cause, right? And see if it gets better. After I did those things that I think might be causing it, then I might put that patient just on a beta blocker. Give him some metoprolol, give him some IV diltiazem, something like that. Slow him down. Once I've gotten everything corrected. Yeah. I would give him fluids, check the electrolytes first, and try to correct that stuff. And then, yeah, I would probably give him a bolus of diltiazem because that really isn't that fast, right? See, you give him a bolus of diltiazem first, see how it goes, and then if you need to start a drip, then you start a drip. Then you don't need to give it. You guys probably wouldn't have time to give him the diltiazem anyway. You guys give him fluids, treat the other things, try to get the fever down, whatever is underlying cause. See, yeah, if you talk to the patient and you talk them into it, we don't really need to shock you, but I want to, and it's cool. Do you think is that all right? What's cool is I'm going to give you a medication that's going to make you totally high, and then I'm going to shock you.
Awesome. Like a roller coaster.
You feel kind of crappy right now. I'm going to make you feel real good.
So you could do a vagal maneuver.
Yeah, you can try a vagal maneuver.
Give them IV.
Sometimes a vagal maneuver doesn't necessarily take them out of the rhythm, but it can slow it down so that you can recognize the rhythm. Sometimes if they're too fast, too tachycardic, you won't even see P waves. You don't know if that's MAT, you won't know if that's SVT, you won't know what it is until you slow it down a little bit. Vagal maneuvers can slow it down enough for a short period of time that you could print out a strip and look at it and try to figure out what's going on.
The other thing I was going to say is that he's asymptomatic, he's just sitting there stressed out.
Yeah.
But
just be like, I can feel the palpitations, but
would you still give diltiazem, or would you just say, hey, let's?
I would try other things first. I would check their labs. I would give them fluids. Check their urine. Check for any other things that's causing stress. And then once I've fixed or addressed those things, then I would do diltiazem. Because diltiazem is not going to work until you fix the underlying cause, right? Sometimes you'll get patients, and I see it in the ER all the time with some of my physician assistants, that they'll get AFib with RVR, and they'll just put them all diltiazem drip, and then be like, I've got them maxed out on diltiazem, nothing's happening. Why aren't we fixing them? Well, dude, they've got 103 temperature. If you address that, they've got hypokalemia and a little bit of hypernatremia because they're super dehydrated. If you fix that, no, you won't fix the tachycardia until you fix the underlying problem. Medications won't work until you fix the underlying problem. No, but you try that pre-hospital. Be like, dude, first I'm going to take this bag of ice, and I'm going to kind of scare you with it and throw it on your face. Then I'm going to shove you full of morphine and Ativan, and I'm going to shock you. We'll take the water off before I shock you. But it's going to be super cool, and we're going to fix you. The only time I've ever used the bag of ice is with little kids. Adults just get pissed off. Little kids, they get pissed off, but not enough to.
Parents don't get pissed off.
Parents, depends on if the parents are in the room, Or sometimes I'll ask the parent. I'll be like, we've got a couple of different options. I can try this first before I poke them, before I do anything, if you're okay with it. And parents will be like, well, if it saves a poke or whatever, then we can try it. But I have to tell them it might not work. Like it's not a guarantee. But it's worked on infants because infants, they get that shock factor and they hold their breath for like 10 seconds, and that sometimes freaks out the patients, but it fixed their SVT. On patients, if you can get a patient to really follow directions and do what you want, you can get them out of SVT without medications, without adenosine, with just increased intrathoracic pressure. Like, breathe with me, take a couple deep breaths, and then bear down. And you sit there and you look them in the eye and you hold it. So they're bearing down as long as you want. And then they have to let go, and you're really pushing them to hold it as long as they can and bear down. And then they take a deep breath. Okay, take a couple of deep breaths now. Big breath, hold it. Like, you go through it with them a couple of times, and you'll see that SVT start to slow down and then reset. That's cool sometimes. And you can fix them before they get to the hospital. What's that?
You can't use tube and hit
You could gag them with a tube awake. You might have some issues with that. All right. So, like I was saying, treatment is directed at the underlying cause. If you don't understand what it is, you can do vagal maneuvers. You can give adenosine. If they're, extremely symptomatic and you don't think that you have time to fix it, sometimes you don't want to wait 3 hours with a patient tacking away at, 180. You want to try to get them slowed down while you're treating the underlying cause, right? And sometimes you can slow them down enough that they're not as anxious, and then they can reset. Sometimes with adenosine, they'll reset, but they just might go back into it if you don't fix the underlying cause. They might slow down into a normal sinus rhythm, tacking away because the underlying cause isn't there, and then jump back into MAT or SVT or whatever kind we're talking about. So you guys understand where you're palpating with the carotid, right? Because the carotid is that whole length of the neck. You want to get kind of where that bifurcation is. That's where those baroreceptors are, and that's where you're massaging. Yeah, you can totally gag them.
You were incredible.
Just sneak up on them
Awake, fully awake.
with an OPA.
Intubation.
The only problem with that is then you have to deal with the vomiting. And the patient is stressed.
That's what you have BLS for.
Chronic or carotid sinus massage. There's a lot of pictures on that. I'm not sure why. So adenosine, what does adenosine do? It's right there. So it shuts off your SA node and your AV node. All right, so it just basically kind of puts a pause so that it can reset. What's the risk with adenosine? I mean, it's generally safe, but it has happened. Yeah, you can put them into VFib or AFib. What's that?
How that put them in VFib?
Because if you completely stop conduction, then sometimes the heart can kind of get this stunned effect and then just start fibrillating, and then it's not able to reset.
So your Purkinje wouldn't take over? Does it block those?
No, not necessarily. It depends. I mean, there's different things that can happen. It's rare, but if you do that and block the conduction pathway, a bad heart might go into AFib, or could go into AFib, could go into VFib, could become bradycardic, but that would be very short-lived, because if they're resetting and there's nothing that's interrupting the SA node to refire, then they're not going to stay in a bradycardic state, right? You might get a couple of beats that are slow with the Purkinje system, and then the SA node will start going because there's nothing interrupting the SA node. But with AFib and VFib starts fibrillating, then you got this constant conduction system causing the muscles to contract and repolarize, but there's nothing significant, and it's confused and it's just in the stunned fibrillating state. Then it's not, that stimulation is interrupting anything that the SA node could do to refire. So then what do you got to do if they're in VFib? Then you just defibrillate them to reset them again.
That's what we want to do in the first place.
Right? I told you we were going to shock you. And now you don't even get the Ativan. You just have to deal with the shock, idiot. Depending, if you give WPW, a tachycardic WPW, the wrong medications, then yes, that's the risk. Is you don't want to give them adenosine, you don't want to give them calcium channel blocker, beta blocker. You don't want to interrupt that because the risk is that they'll go into VFib. WPW specifically is more prone to do that. Other dysrhythmias can, it's just really rare, right?
You don't want to give adenosine, but if there's any issues with the SA node.
No, you just don't want to give adenosine specifically if you know they have WPW. Most of the time, if they have that, they already know that they have it. It's been recognized. It's caused, problems or whatever issues before, and it's been recognized. The rare occasion that you get a tachycardic patient and you didn't know that they had WPW, and you find out later that they did after they went into VFib, and you shocked them and you brought them back, and oh wait, shoot, they had WPW. Yeah, but we didn't know that.
So on the contraindications for this, for size, second,
Doug, told us to add. On that.
Yeah. Well, I was just
So what are your other contraindications?
for size, second, and third degree heart block.
AFib?
Yeah.
I don't think that's a very strong contraindication. I would say most cardiologists would say you could try. I mean, we don't normally give adenosine for AFib, right? We treat it other ways. We shock them, we give them diltiazem, we start them on a drip, we treat the underlying cause. But sometimes you don't know because it's so fast. You don't know, is this AFib, is this whatever, and we'll give them adenosine just to slow them down and find out what's actually going on. The adenosine normally won't work to reset AFib, but you can give it to slow them down. So I don't know what the contraindication is. Yes, there's a risk that they could go into VFib, but it's pretty low with AFib. Probably similar to most of your other dysrhythmias.
So what I do the same for like second and third degree block is you can't see an AFib so fast. They can't see the P waves.
Yes. Third would be really slow, depending on what kind of second. You could get a 2-to-1 that you don't know if that's, but usually they're not fast.
You're talking at like the 180 level?
Yeah, those AV blocks usually are not fast.
Okay.
Unless they have something else on top of it that's like one of these, right? Because you can have an AV block and extra pacemaker cells causing paroxysmal SVT or whatever, right? Then you're really having a hard time trying to identify what's going on. All right, so where are we? Okay, SVT arrhythmias. So these are above the bifurcation, begin in the SA node, atrial tissue, AV junction. Anything above that bundle of His, right? Types of SVTs. All right, so technically, you know, on multifocal tachycardia, we kind of lump it into the same category SVT, but on a technical basis, it's not an SVT. This is the AV NRT. This is atrioventricular nodal reentry tachycardia. This is where you get, well, I guess it shows the picture underneath, where you get just the cyclical loop at the AV node, causing continual contractions and conduction through, and you get this tachycardia. I think the AV NRT is easier to recognize than the AV RT. Sometimes. So the AV RT is where you've got extra tissue and you've got a reentry pathway. So normal PAC, you've got this extra tissue sending a conduction through, but it's not reentry, right? In this state, you've got this extra tissue and it's just causing this reentry. With the nodal, it's just right there at the AV node.
I thought a PAC will stay in the atrium.
A PAC? A PAC causes an electrical impulse that eventually gets the AV node and conducts down, right? It causes a QRS. So it depends on the patient's anatomy, right? A normal PAC will just stimulate, cause a conduction, cause a contraction. In this case, it stimulates, and then when it comes down, there's a pathway where it goes back up. Okay. So there's a break in that connection between the atria and the ventricle, and there's a pathway where that conduction goes right back up. Because normally, you know, the only thing getting through that that pathway is, I mean, you've got the valves, and you've got all that cartilaginous fibrous tissue creating the valves and separating the atria from the ventricles. But sometimes there's a break, and there's you know, a path for the electricity to get back up and create this reentry pathway where it keeps going. And it goes back up and stimulates it again. Stimulus goes down, and then that reentry pathway goes back up, stimulates it again, and it's a never-ending cycle until you interrupt it, until you fix it. Make sense? You guys understand the difference? So, because it's a reentry and that stimulus is going back up, what does the P wave look like? Inverted. Because that impulse is going back up. So you get an inverted P wave. Right? Because now your stimulus is going the opposite direction as what that lead normally is picking up.
Or the P wave?
It's not.
Inverted here.
You might be looking at a T wave. Look at where the arrows are pointing. So up here is atrial tachycardia. This is just, there's no reentry, right? So you've got P waves that are upright. So atrial tachycardia, I mean, could be theoretically, you know, a PAC that's excited and taking over for the SA node. That's become an atrial tachycardia, right? It's not a. And then down here you've got reentry, and so that impulse is going back up the atria, just like here you've got reentry, so you've got an impulse going back up, and you get inverted P waves. See how those are, well, this is, and that's another thing we're going to talk about, is with AV-NRT and AV-RT, your P wave can be before, can be in the QRS, and you won't even see it. It can be after the QRS, and it'll look like an ST depression. That's actually an inverted P wave. So that's why sometimes it's hard to recognize because the P waves aren't in the right spot. Because of the reentry excitation, you don't know when it's gonna show up and how often the QRS is actually gonna fire because of it.
How do you distinguish between atrial tachycardia and just regular tachycardia?
There'll be a change in what morphology? P wave morphology. So if a patient just comes in with atrial tachycardia and you don't have any, information of before they started, then yeah, it's just going to look like a sinus tachycardia to you, right? So atrial tachycardia, for the most part, is just going to look like sinus tachycardia until you slow them down, and maybe it'll reset, and then you'll see on the strip, oh wait, it's suddenly changed. This wasn't a sinus tach, this was an atrial tach, and now we've given it back to the SA node. All right. Sometimes you won't see it until you fix it.
So once we get it slowed, what's the P wave that we do?
It'll change back to its regular SA node P wave morphology. Any other questions?
I was going to ask, so given the rate on AV and RT or AV and RT,
Mm-hmm.
you may not see the P waves at all.
Nope. You might not.
What about what rate? Would you expect
Especially the P waves that are before the QRS, you probably won't see. P waves after the QRS, you might still see, because even with a tachycardia, the ventricular rate can only max out so high, and it has to repolarize, right? So you'll still get there'll still be a time between the ST segment where you might get an inverted P wave and be able to recognize it. But in this case, do you think that that's the only P wave going on? Probably not. You probably have P waves in the QRS, and the P waves are going along. You're just not seeing all of them. You're only seeing them when you get a firing of the ventricle.
So how would you differentiate
AVR, we'll talk about it.
Or even a multifocal, too, if it's, you think, oh, well, just this flat P wave could be originating from somewhere else.
Yeah, multifocal could be. That's why I say multifocal is kind of grouped into the same general idea because oftentimes it looks the same.
Okay.
Multifocal, though, multifocal will be regular, irregular.
Irregular.
Multifocal will be irregular for the most part. These ones generally are regular. So when you're going down the tree, you can say, well, is this regular, irregular? Irregular, I'm looking at MAT, maybe AFib, different. If it's regular, then I'm looking at, atrial tachycardia, AVNRT, AVRT, those kind of things. All right. So that's kind of the first branch where you can differentiate them. Is this regular? Is this irregular? Do they have a P wave? If they've got a P wave and it's irregular, then I'm going to start looking for other P waves, see if this is MAT. If there's no P wave and it's irregular, then it's AFib, right? So you can kind of make this branch, start differentiating. Maybe I should do that. Make a little tree for you. All right, so atrial tachycardia, that's that first one that we were talking about. So series of rapid beats from an ectopic focus, from cells, pacemaker cells other than the SA node. And then it overrides the SA node, and you're only getting firing from this other tissue. So yeah, atrial tachycardia is basically a run of PACs, right? If you got 3 or more PACs in a row, that can be considered atrial tachycardia. Does that make sense? Because that's basically what atrial tachycardia is, right? It's PAC that just keeps going, that's taking over the SA node. Paroxysmal atrial tachycardia. What's that? So yeah, you get a run of PACs and then the SA node takes back over, resets. That's paroxysmal.
When you say 3 or more, you mean between an R to R?
No, just 3 or more PACs in a row. So you've got a normal strip with normal sinus, and then you get 3 PACs right in a row. That can be considered a run of atrial tachycardia. But it's paroxysmal because it stopped and then your SA node took over again, right? And if you get a run of PACs like that, so a run of atrial tachycardia, that's very common for people getting palpitations and never being able to pick it up, because when they come in, they're in normal sinus rhythm again. And you're only going to catch it when they go into it again. So either observe them for a long time, put them on a Holter monitor. Sometimes it doesn't work. I wouldn't say usually. I would say just
the way you said
it can.
They come in and they're back.
Yeah, that happens frequently. But we also get patients that come in with the atrial tachycardia, or because atrial tachycardia is a form of SVT, and we get patients come in all the time with they can't stop it; it's just going. That's when we try the vagal maneuvers, the adenosine, and everything else, right? Sometimes we get and you get patients all the time that I'm getting palpitations and they're going on and off all the time, and sometimes those are hard to figure out what's actually causing the palpitations, because we have to catch it and see it to know what it is. All right, and to catch an atrial tachycardia sometimes is tough. Sometimes you don't even recognize that the P waves are different. So this is just an example of what part of the QRS and P waves that you're getting, and how the impulses are going through. All right. So this is an example of when the atrial tachycardia stops and goes back into a sinus rhythm. Do those P waves look all that different? Not a whole lot different, right? In the atrial tachycardia, they might be a little bit more peaked than the normal sinus, but sometimes it's hard to recognize. Now, the fact that just spontaneously they go from tachycardia to normal sinus rhythm, that will clue you into, oh, I got to look at the P waves a little bit closer, because there's a reason why they went tachycardic to normal so quick. It's not just that they just automatically stopped, right? Because the tachycardia should normally slowly slow down. All right. How do I recognize it? The different shape, we talked about that. Okay, so this gives you a kind of a definition of, depending on where that site is in the atrium, will give you a different shape of the P wave, right? And we kind of went over that before with Trevor's question of why the P waves change, and why they have different shapes, because they're different aspects of the atrium. And I would not expect you to memorize that if it's in this spot of the atrium, it's going to cause this kind of morphology. I just want you to be able to recognize different morphology, right? I don't care if you know where in the atrium it's coming from. So this is considered paroxysmal because it spontaneously stops, it goes back on its own, caused by all the same stuff. All this stuff is caused by the same stuff, right? Sympathetic drive or stress physical or emotional. These are the signs and symptoms that patients are going to get. Sometimes they don't feel them at all. It's funny, sometimes we'll get old people in and they're in AFib, tacking away. They're like, no, I feel great. What did you come in here for? What did you come in for? They came in for like a urine infection or something. Like, you're in AFib. Oh, I feel fine. Sometimes people just don't even feel them. They get palpitations, fluttering of the chest. Sometimes they can cause chest pain. Chest pain is one that's sometimes difficult because it's really easy to say, oh, the chest pain's because of the AFib. Well, they might be going into AFib because they had heart disease and a heart attack, and you're not seeing it because they're tacking away. And once you fix the AFib, then you're like, oh, yeah, you did have a heart attack this morning. We should probably get you to the cath lab. All right. So what do you do? Vagal maneuvers, adenosine, beta blockers, calcium channel blockers, amiodarone. You know, amiodarone is actually a really good fix for AFib. It's got worse side effect profile than the other ones, so we don't use it as often unless the other ones don't work, but amio is great for a lot of these things. So coronary and peripheral vasodilator suppresses the SA node function. It can cause a little bit wider QRS, slows conduction at the AV junction. Side effects, this is why sometimes we don't use it. It is more prone to hypertension and bradycardia, depending on how fast and how much you're giving, and it can prolong the QT. Amiodarone actually has multiple functions. It has calcium channel blocker, it has sodium channel blocker in it. Depending on which dose you give, will have different effects on the patient. So this is synchronized, right? You got to synchronize it. Why? What is happening when you synchronize it? When do you want to shock a patient for synchronized cardioversion? I mean, the machine is identifying the main complex, right? Either the machine is detecting the greatest amplitude, either positive or negative. So R wave or S wave. But when is it actually shocking the patient? When is it delivering the electricity? Which part of the QRS complex would you think? If you want to reset, is it going to do you much good to shock them during depolarization?
No.
No. So when does the machine shock them? Repolarization. So yeah, with the T wave. It identifies it. You'll see the tick marks on your machine at the biggest amplitude, but it's actually giving the electricity during repolarization.
So it's got to be regular, correct? Or can you do it if it's irregular?
No, it can do it with irregular. The machine will detect each one, and then it'll give the shock right after a QRS complex at the right time. But yeah, I mean, we synchronize cardiovert AFib all the time. So it doesn't have to be regular. All right. So this is just indications for cardioversion. So basically, any tachycardia over 150, you can cardiovert, whether it's VTAC or narrow, wide or narrow, you can cardiovert. What's the difference with VTAC? If it's stable VTAC, what kind of shock do you want to give them? Synchronized or just defibrillated? Stable VTAC, synchronized cardiovert. Unstable VTAC, You just defibrillate them.
What do you mean stable? They would actually have a pulse that was stable, right?
Stable, yeah. Well, they have a pulse and clinically,
Just a little vibe.
yeah, they're not hypotensive. They're not, their brain is being perfused. They're talking to you. The patient is, I mean, it's relative, right? It's a relative term. They're relatively stable. All right, this goes through the cardioversion procedure. You guys all know how to do that. I love the clear.
No,
Hands up. What?
I've never seen.
You guys don't know how to cardiovert?
I've never seen a cardioversion in my life.
Okay. So you got the pads on, right? And actually, in my opinion, the pads front to the side is a bad idea.